Hi, I'm Carly. I'm the attending physician this week, and I'm going to read us our case study. So we have a 94-year-old Caucasian man presented to our hospital with extensive bleeding from his oral cavity and diffuse bruising. His medical history included severe dementia and hypertension. Our patient had a habit of repeatedly biting his tongue. This led to profuse bleeding from the dorsal surface of his tongue that was persistent despite surgical placement of sutures in the tongue and removal of his teeth. His hemostasis was previously normal, and he did not take any anticoagulants or non-steroidal anti-inflammatory drugs. There was no nosebleeding, hematuria, bloody stool, or accompanying hemoptysis. Our patient did not have any family history of bleeding disorders. On examination, his vital signs were stable, and he was afebrile. There was profuse bleeding from the tongue with the presence of multiple clots in the oral cavity. No other bruising or active bleeding was noticed, except extensive bruising over his upper extremities with the presence of a hematoma on the left hand with active oozing. Laboratory tests revealed a white blood cell count of 9,500 cells per microliter, with an initial hemoglobin level of 11.7 grams per deciliter and a platelet count of 149 by 103 cells per microliter. Coagulation studies revealed a normal prothrombin time of international normalized ratio and a prolonged activated partial thromboplastin time of 73 seconds. Normal is 24.8 to 36.1 seconds. The presence of an inhibitor of coagulation was diagnosed via prolonged activated partial thromboplastin time and a mixing study that did not correct with the addition of normal plasma. Partial thromboplastin time, or PTT, 36.4 seconds when an immediate mixing test was performed, with the ratio of patient plasma to normal plasma 1 to 1. Quantitative assays revealed a reduced level of factor VIII, activity 1%, with the presence of factor VIII inhibitor measured at 7 bethesda units, or BU, in the serum. Our patient was not intubated for airway protection based upon the wishes of his family. In total, 2 units of fresh frozen plasma and 8 units of packed red blood cells were transfused, and 3 doses, 100 units per kilogram of recombinant human factor VIII, humate P2958 RCO, were given to our patient as initial management. Acquired inhibitors against factor VIII, also termed acquired hemophilia A, is our prognosis.